So, hello, good morning, everybody.
Good morning.
How are you, my dear Lisa, dear
Excellent.
Stan? How are you? How is everything in United States, in Sweden? Hello, Ismail, in Turkey. My dear Ron, hello from USA. Erki Bianco Monjari from France. And Philippe de Jonker from Belgium. Xi Jing,
Yes, hello.
welcome, new member 26. Pigu, great to see you from New York. And Leslie Childs from Dallas, our also brilliant new member 26. And well, we shall begin with our first session 26. I really am very glad to see you, and I welcome you to the new activities of 26. Hello, Wolfram, Professor Wolfram Steiner, fantastic, from Berlin. So we shall begin, and I wish you the best for you, your family, your friends, your scientific groups, and of course your patients. A happy new year, full with health and with success and with love. I am sure that the board of Comet has improved, and of course we shall be together all this year. And we shall begin with our session. As I sent to you, the 26 activities are already with dates. Please check the dates because we need, one moment, we need to be together in all the activities. Can I have the next slide, please? And as you see in the next slide, we have our Comet World Voice Day 26 in 11th April. This is a 27 online session. The 11th July, we are organizing a very nice session. And if you are interested in participating, please let me know. This is important to know the pathologies, diagnostic surgery of the laryngeal superior nerve. We have already been talking about that. This is a proposal from our dear Liza, and this is great. And we also have our annual conference from 1st to 4th October in Münster, Germany, with our dear Katrin Neumann and Philipp Mathman. So I invite you that you please send your topics and save these dates in order to join us in Germany. As you know, last year we were in Paris, and this year we are going to be in Germany. And our General Assembly, this is 7th November, and very important, please come to PBOK 16 Voice Istanbul in the wonderful city of Istanbul. This is going to be 25 to 28 March. And of course, Comet has a special session there that we have already a very nice program. The next one, please. So we are going to begin today with this special tribute to our very dear Comet member and friend from so many years, Krzysztof Izdebski. As we know, Krzysztof Izdebski has been a very important pillar in voice science, and he has been making many world congresses and, of course, many congresses in San Francisco and, of course, in Poland. So Philippe de Jonker from Belgium is going to talk about Philippe. So I give you Philippe. Thank you, Philippe.
Thank you, Eugenia. Is it possible to show my slide?
Yes, and I insert, in order to have it properly, I insert your text. The next one, please. It's going to be in the blue window, Philip, what you wrote about. So I put that all together,
okay,
that it's going to be easier. So please, the next one.
Okay. Yes, dear Eugenia, first, thank you for giving me the opportunity to pay tribute to an old friend whom I had known for more than 40 years. Dear friends in Comet, our dear Krzysztof left us on May 27th, 2015, 25, sorry, at the age of 50.
80.
Yes. 80. When I received this mail, I hope you see my slide with Krzysztof next to the piano.
Yes, yes.
Okay. When I received this mail on June the 6th of last year, it took me some time to understand. My first impression when seeing Krzysztof looking so cheerful and smiling next to a piano was he surely is organizing a conference on singing voice. When I realized the truth, I remembered a sentence from his last email, but in the context of a collaborative project on post-COVID dysphonia, he wrote, "For me, game is over." However, even then, I imagined that he simply did not plan to continue actively contributing to the project. Krzysztof was born on March the 6th, 1945, in Milanówek in Poland. He first graduated from the University of Lund in Sweden, and then he arrived in the United States in 1970, and he was naturalized in 1976. He became Master of Arts at the University of California at Los Angeles in 1972 and got his PhD at the University California San Francisco in 1976. And this PhD thesis was on the topic of minimal phonatory reaction times. He was proud to tell he had been the first ever doctoral student in the field of science, in the field of voice science, within the University of California. In that time, he was working together with Thomas Shipp, and they published together on that topic in 1978 in a Journal of Speech and Hearing Research. In 1985, he was appointed Associate Clinical Professor of Otolaryngology at the University of California, Davis, Sacramento, and also at Stanford University. Moreover, Krzysztof was affiliated with the San Francisco Conservatory of Music as Professor of Voice Science, as he had a special interest for singing. We all know Krzysztof as the founder and chairman of the Pacific Voice and Speech Foundation, and as the organizer of the annual Pacific Voice Conference, mostly in San Francisco, but also, as Eugenia already said, sometimes in his beloved Poland. Indeed, the 27th edition was in Krakow in 2019. He also was the co-founder of the World Voice Consortium and the editor-in-chief of ePhonoscope, an electronic journal dedicated to voice research, care, art, and technology. Krzysztof defined himself as a voice and speech pathophysiologist. After the topic of his PhD thesis, his scientific work has focused on multiple fields. Allow me to mention only the main ones. In the beginning of his career, for many years, he worked closely with the famous laryngeal surgeon Herbert Dido on the phonatory movement disorders and particularly the spasmodic dysphonia and its treatment. Very early on, he drew attention to long-term problems of surgical treatments. Another of his fields of interest was the modeling of coding and decoding of emotions in the human voice. He was the editor of the 3 volumes Emotions in the Human Voice. Still another domain in which he published and contributed significantly is voice assessment, and particularly innovating methods for assessing vocal fold kinematics, a subject on which he edited 2 volumes. He was interested in applying these assessment techniques to occupational voice and to medico-legal evaluation. We had long discussions about comparisons between American and European viewpoints and dissimilarities. I also very well remember how in our last mail exchanges we discussed, together with John Rubin within the voice committee of the UEP, about the long COVID dysphonia. Krzysztof was preparing a supplement for his book on evaluation of workers' compensation claims in the field of voice, speech, and swallowing. Krzysztof was also a man of great culture and could take an interest in original subjects, like the speech of Neanderthals. As a multilingual speaker, Krzysztof was a frequent lecturer at numerous European, Asian, American, and South American congresses. I very well remember when he visited me in Utrecht in 1992, but also when we met at several Pacific Voice conferences, at Maviba with Claudia Manfredi, in Ravenna, La Voce Artistica with Franco Fussi, in Salzburg with Josef Schlömicher-Thier, in Coast Action 2103, in Krakow, and of course in Comet meetings. What mainly remains me personally from Krzysztof is his unalterable scientific enthusiasm and his indefectible faith in the future of research. Several of his last lectures dealt with artificial intelligence and deep learning, as if he were a young researcher. However, beside the scientist, he was also a music lover. This undoubtedly explains the choice of this photograph, in which he is depicted next to a piano. Dear Krzysztof, beyond your scientific excellence, we remember you as a noble and gentle person, and even more, as an always thoroughly faithful friend. Thank you for having been with us, for what you brought us and meant to us. Our thoughts are with your family. Now, Krzysztof, rest in peace. Thank you.
Thank you very much, dear Philippe. And now we shall hear some words from Austin King, also to Krzysztof as a tribute. Thank you, Austin.
Eugenie has asked me to comment about the passing of Chris Izdebski, and what can you say about Chris? That he was iconic, he was quirky, he was certainly dramatic, but he had a consuming passion for voice. I met him intermittently over many voice conferences, but really got to know him when Dick Stasi and I hosted the Comet in Houston in 2018. He called me all upset because naturally his plane was delayed. He'd missed the welcoming dinner and reception. And so my nurse, who was helping me with the conference, and I picked him up, took him to a Texas diner where we introduced him to Texas bourbon and whiskey sours. And he seemed to really enjoy the whiskey sours. In fact, after 2 or more whiskey sours, we became very close friends. He then invited me and my voice lab to the Pacific Voice, which we went the next year and presented. And of course, Chris seemed to know everybody around the conference. And as you probably well know, San Francisco is home to the world's homeless, I think. And when we were walking to the conference facility, we had to step over a gentleman laying on a street corner. And we turned the corner and I ran into Chris and said, should I call an ambulance or kind of wake him up to examine him? And he said, absolutely not. He said, if you wake him up, he'll be very angry. And that has been his corner for many, many years. And sure enough, we left the conference, the gentleman was gone. But Chris seemed to know not only everyone around the conference, but also the San Francisco street people also, which is no surprise knowing Chris. Well, he also asked us to help him when he was putting on a conference in his home country of Poland, in Krakow, which we did. And there he introduced us to Polish vodka, which I think was better than the Texas whiskey sours. But over a couple of vodkas, he told me a little bit more of his story of his life, where he, as a child, had been there for the Nazi occupation, and then as a teenager for the Russian occupation, and the Russians were even worse than the Nazis. And he realized that to go on to university, he'd probably have to join the Communist Party, which he absolutely refused. So he escaped to Scandinavia and finally made his way to the United States and was educated along the way and became to have a passion for voice. These unusual life experiences, I think, formed his sometimes unusual thoughts about life and about life's experiences. And I'm afraid that with his passage, Comet and life will lose a little bit of his spice, and he will be missed.
Thank you very much, Austin. And I would like to acknowledge our dear Chris. And of course, he has been a friend from many of us, and we have been together in many of the scientific congresses, symposiums, workshops, and many of us, we were also visiting his private practice in San Francisco and his family. And I do remember when we were joining in the in the embassy from Sweden, because he had a very close relationship with the ambassador of Sweden in San Francisco. So it was a great human being and very passionate. And of course, he was all over the places in the very important situations. For example, he was with us in Houston in the Comet wonderful meeting that our dear Austin King and our dear Richard Stasny, Dick Stasny, organized for us. And hello, dear Dick and Catherine, and of course, Andrea. And I would like to acknowledge that that was a very nice Comet meeting annual conference in Houston. And as you see here, Chris was taking part on the academic and, of course, on the social situations. And he was also in some of our Comet academic sessions online. As you know, we began with our academic sessions online when we began with the coronavirus pandemic. And of course, now we have been online many, many years. So just to summarize a little bit, he was also a collaborator of the Vox Institute, and he was all the time talking about physiology of vocal communication. He was also world authority in professional voice and speech physiology, pathology, care, and rehabilitation. That's why our dear Philippe says that to name himself as pathophysiologist. And he was, as Philippe already said, founder of the chairman of the Pacific Voice and Speech Foundations. And we do know how much work and how much passion does it need to organize these congresses. And San Francisco was one of the you have to be there in order to have this collaboration with all the group that Chris gathered at that times. He had several academic positions all over California and of course also in Poland and some international also. And it was important that he was coordinator of San Francisco Coalition of Arts Medicine. So he was all the time talking with singers, with actors, with vocal coaches, and of course, he also worked in his private practice. And he was, as we know, very close to Herbert Dido and some other personalities. And for his contribution of the profession, he was nominated also as a fellow of the American Speech and Hearing Association, ASHA, for outstanding contributions to the discipline of communication sciences and disorders. He was also awarded the highest prize known as Stroboscar by the US-based Voice Foundation for his research and visualization of the kinematics of the vocal folds. The next one, please. So, as we know, also he was as editorial board of Journal of Voice and reviewer of other scientific publications and co-founder of the World Voice Consortium. We do remember Porto and some other places for example, also in Korea, that we were together in this World Voice Consortium Congress. And he co-produced through this organization 5 different World Voice Congresses. So I want to show you, and if you please allow me some technical change, I want to show you some of the slides that he made for our comment session online in 21st.
Good morning. I'm Krzysztof Izdebski. I am responding to the order of Eugenia Chavez to present this discussion on practical examination of breathing. When evaluating a singer in trouble, a crucial part of my test is examination of breathing. No, I don't use the balloon. Although clinical equipment can be used to obtain more precise information, such luxury is rarely available in clinical settings, so alternative means must be applied. I follow 2 simple steps. One is my perceptual evaluation of vocal effort and body posturing of a singer, and then I ask singers to describe me his or her own perception of what's going on, and I compare those 2 results. I relate my observations to the following pattern of efficiency of breathing. This is presented in this graph of physiological pattern of voice frequency change. Concentrates on those 2 lines, the blue and the red. The blue line is the flow of air and the red is subglottic pressure. You see how things change depending on what the singers will actually do. My reasoning for the exam is to relate singer lungs volumes to perceived effort, body positioning, and to sound quality. Ventilation differs from normal speech breathing in singers, but must be efficient as well. Breathing in must be provided by loose abdominal tension and inhalation by mouth. Breathing out must slow down air escape. Body posture is crucial to allow for unobstructed diaphragm movement. Breathing in, diaphragm goes down. Breathing out, diaphragm automatically goes up. No need to push or support with the diaphragm. It doesn't work. Let's review the enemies of inhalations. Number 1, body rigidity, breath conservation, air holding, evidence of imbalance on inhalation and exhalation. I try to observe posterior, anterior, and lateral chest expansions and passive diaphragm movement during expiration. Variability will be great among singers and styles, but remember, abandon breath and sing on the diaphragm phrase. Enemies of exhalation. Again, body rigidity. inadequate training for style, adynamic ventilation with inefficient voice, unstable laryngeal position, and overcontractions of extrinsic laryngeal muscles, improper control of subglottic air pressure versus body type. Group of Tom Hickson from University of Arizona have created a large volume of literature regarding controversies of breathing technology or techniques by singers, and based their research on evidence of stage success. They concluded that variability of breathing technique is individual. No singular correct breathing for singing exists. Idiosyncratic patterns by body type dictate how people breathe. They say, let singers rely on successful patterns, allowed to continue, and do not correct by theory. Following initial examination of a singer, I apply my simple model of non-injurious inhalation and termination of ventilation for any song. This is shown in this simple graph representing inhalation and exhalation. What's very important here to note, the two blue arrows showing when I would like a singer to start vocalization and where to end vocalization. And I have a technique in which they communicate to me the degree of effort that they observed when they're above or below the blue lines. The next two slides show airflow during speech and singing. These photographs are taken through thermography, and let's observe that in this case, during speech, the flow of air falls towards the ground. This thermograph shows flow of air during song from the same person. You can observe that the air goes upwards, and the reason is that there is a difference in consumption of oxygen and carbon dioxide between speech and song. Well, that ends my talk. Thank you for listening. Good luck. Gracias por escuchar. Todo lo mejor para sus cantates y buena suerte.
Collegium Medicorum Theatri honors him with this small tribute, and thank you very much, Philip and Austin, for this. And of course, I thank you all for your presence here. And dear Chris, we think of you, we miss you, but you are all the time with us. Thank you, Chris, for everything what you did for the communication science and for your legacy. Now we are keeping on with our program, and I would like to present Dr. Xijing He. You already know, you voted for her, and I shall read a very short curriculum. She's graduated from the University of Edinburgh, the Royal College of Surgeons of England, fellowship-trained consultant ENT surgeon, and she's acknowledged from the Royal College of Surgeons. And also, she's a laryngologist at Geese and St. Thomas Hospitals, as well as King's College London in the UK. Special expertise in voice, airway, and swallowing disorders, with interest in the care of performers and professionals voice user, is, of course, one of her main expertise. Her practice spans the full spectrum of laryngology, encompassing both in-office and general anesthetic approaches to diagnosis and treatment delivered through a patient-centered and holistic framework. And she has completed ENT specialist training in the east of Scotland, and she's also accredited by the Royal College of Surgeons, as I said, of England, and she has a laryngology fellowship at Geese and St. Thomas NHS Foundation Trust. Her subspecialty interest was further enhanced by time spent at the Massachusetts General Hospital Voice Center in Boston, USA, with our dear Comet member Steven Seidels, and the University Hospital of Rouen in France with the great, fabulous Jean-Pierre Marie. She is an elected member of the Faculty of Surgical Trainers at the Royal College of Surgeons of Edinburgh and holds a postgraduate diploma in clinical education. Of course, this is a short, very short, and now we shall enjoy the presentation of Xi Ying with regenerative voice care with platelet-rich plasma is a potential application in the artistic voice. And I may say, Antoine Giovanni, Monchei, welcome. Thank you.
Thank you very much, Eugenia, for the introduction. And it is a great pleasure to meet you all here virtually on the Comet meeting. It is also a great privilege to be able to join this very prestigious organization. My name is Xing He, and I'm currently an ENT consultant and laryngologist working at Guy's St Thomas's Hospital in London. The topic I want to talk about today is something quite dear to me. It is a regenerative voice care using the platelet-rich plasma, and it will be interesting to see how it can be potentially applicable into the artistic voice community. I think it'd be useful to go through the talk looking at what is PRP and what does it do, what do we use it for, and how do we do it, and also what are the outcomes so far. So in terms of PRP, it is abbreviation for platelet-rich plasma. It comes from the patient's own blood by taking the blood from the patient, and then you put it into the centrifugation machine. And after these, what it gives you is an autologous sample from the patient of highly concentrated platelet-rich plasma. And within these, it is a cocktail that is rich in growth factor, cytokines, chemokines, fibrinogen, and many other stuff that are essential to promote tissue healing and repair, which the blood content naturally have, but this is more of a concentrated solution. The use of PRP is much more wider known outside ENT. And this is more commonly with lots of literature coming from rheumatology, orthopedics, and for instance in the UK, PRP is used and recognized by our NICE committee for knee osteoarthritis. It is also commonly used in reconstructive surgery, such as Max Fax, where they want to put in certain flap. They use the PRP not in a liquid form, but in more a jelly layer that they insert or sandwich inside their flap to promote flap uptake and tissue healing. Cosmetically, this is also well known, probably more recently by Kim Kardashian of her famously known vampire facial, and that is essentially injecting the PRP into the skin to allow rejuvenation. Hair loss is also another thing that PRP is commonly used for. So now that it has been used quite widely around different medical fields, in terms of voice care, PRP is increasingly used in our community for voice change due to vocal cord scar, sulcus, or atrophy. And these are normally due to either the vocal fold muscle being thinner, or certain layer of the vocal fold being deficient or lacking in function, and this then results in persistent impact on quality of life, and also particularly in the artistic voice user, this can impact on their professional function. Before we go more into exploring the logistic of it, I thought I'd show you what this procedure involves. So this is what it looks like. Patients come through, you draw the blood from them, usually about 20 ml, and depending on your machine and also the setting of the spinning itself takes about 5 minutes using our machine, and with the 20 ml it gives you about 4 to 6 mils in total at the end, which is this golden yellow content. And these will be sufficient to both prime the needle and also to inject into each side of the vocal cord, because vocal cord is not a big place. Usually 2 ml is quite sufficient. And how does PRP improve the voice? Because of its regenerative ability, and we know that a lot of difficult conditions we treat, such as scar, sulcus, or atrophy, and it is due to certain layer of the vocal fold not being fully function or malfunction. And it is thought that depending on where you inject, it can improve the vocal fold volume, restore mucosal wave, and also vocal function in return. The good news is none of the series has reported any vocal deterioration, so what I say to the patient is, worst thing, it doesn't work, which is quite good. And particularly in the mild and moderate dysphonic group, there has been reported up to 80% of voice improvement, not just in the short term, but also in the long term. And I think this is really applicable because in comparison to the more severely dysphonic cases, the improvement is less so, understandably. If you have got a harder scar to treat or more extensive scar, the remodeling might take longer or may not be entirely optimal. So in terms of the artistic voice users, if you are one or performers, it is unlikely you'll be severely dysphonic, otherwise you probably wouldn't be performing. But they tend to become with mild to moderate dysphonia, and these can be really useful in the cohort, especially with the amount of voice improvement that has been reported. And the good news as well is that it is something that is quite easily repeatable and also well tolerated in patients. And this has been shown by a few key literature review from papers that demonstrate PRP use in voice care, with the largest series coming from Pete Wu in New York, where he used PRP for scar, sulcus, nodules, as well as atrophy. And in his prospective case study, he did show that there was significant short and long-term benefit, both in the patient's reported outcome and also other acoustic analysis. And this is again best resulted in mild to moderate cases. Jackie Allen in New Zealand also shows similar outcome and also quite importantly demonstrate that 95% of patients are willing to have a repeat PRP. There are LA papers that again show excellent safety profile and improved mucosal wave, and not just endoscopically but also patient-reported outcome. PRP is also been used at present, as far as we know, in different parts of the world, such as France, in Taiwan and Korea as well, just for voice care. So in our setup, all our patients are selected through what we call the multidisciplinary team voice clinics, where it is jointly staffed by consultant laryngologists as well as a speech and language therapies specializing in voice. Once the decision is made for the patient to have a PRP, it is consultant-led delivery for the early cohort, and all of us will need to undergo centrifugation training beforehand by the manufacturer. And this is how it looks like when we do it in our office. Most of our patients undergo PRP injection under local anesthetic to the larynx topically as an office-based procedure. And the injection to the vocal cord can be performed either endoscopically or transcutaneously, like how you would normally inject into the vocal cord. We will quite prefer a direct visualization so we can see exactly where the needle is going and also to the site of the injection. From the moment patient comes in to get the blood drawn until the time they finish and leave, it doesn't take usually longer than 60 minutes. And as one of my patients put it, it's actually shorter than her haircut appointment. So yeah, it is something that is quite feasible logistically. Our protocol is that all patients will go home on the same day, of course, for those local anesthetic and also for those with general anesthetic. Patients will be advised to take a voice rest up to 24 hours, and some patients prefer to have a bit longer if they feel uncomfortable in their throat. All patients will receive speech and language therapy, vocal support before and after the procedure. And depending on the outcome from the patient and also the etiology, we normally inject up to 3 times a month apart if the patient has got severe scar or not having satisfactory improvement in between. But if the patient has got improvement after 1 injection, we are more than happy to watch it and see how it goes. So it is not a fixed 3 injections, but up to 3. This is an example of a patient of mine. He's now in his mid-40s. When he was a child, he had up to 40 procedures for RRP using cold steel instrument, and this resulted in significant laryngeal scar in multiple sites in the larynx, not just in the glottic level, but subglottic as well. And you can see this is an injection of the PRP using endoscopic needle through a channel endoscope, lifting the laryngeal scar from the underlying ligament, and with a very slow and steady infiltration, you can see this is filling up the entire length of the vocal cord. I would like to inject, in his case, subepithelially, bilaterally, as well as the paraglottic space to make sure he doesn't have a good, make sure he can have a good glottic closure later on, because a gap is his main concern. So this is his recording for his son that was taken before the PRP and after 3 PRP injections with us, and his son is only 4-year-old. I'll let you listen to what it sounds like. This is before.
Would you like to hear Daddy's old voice?
Quite strained.
Would you like to hear Daddy's new voice?
And this is after, where it is much more control, it is deeper, but you can hear that it is less strained and less and more flexible in terms of his pitch variation.
How was your day, George?
This is the before.
How was your day, George?
Again, the same outcome, another round.
Right, let's brush your teeth.
This after.
Right, let's brush your teeth.
He also works in a very noisy environment as a charge nurse for a very busy ITU, so you can imagine lots of machine going on in the environment all the time, talking to family, colleagues over a mask. So this can be very difficult. After the injection, he's very happy that there's no longer any difficulty with phonatory effort, and he's also finding that he can read his son's storybook a lot easier with a different pitch where he can mimic different character. So this is really a huge impact change in his life. This is another patient of mine where he unfortunately has got severe post-traumatic stress disorder. He has got a laryngeal scar, and likely from TB and as well as from sulcus, you can see bilaterally. Unfortunately, because of the war in Somalia, where he is actually in the war refugee in the country, in the UK, he's unable to undergo local anesthetic. Hence, we decided to go for general anesthetic. And similarly, you can see in his case, I also injected within subepithelial layer, wanting to bulk up the lamina propria, as well as in the paraglottic space, so that to ensure the PRP will allow the vocal cord to meet in the midline or until the PRP extrude, which means the area is already fully infiltrated. And this is his endoscopic assessment before and after. So he had 3 injections, a month apart. You can see the sulcus. It's quite a big glottic gap.
1, 2, 3, 4, 5.
And after, you can see his voice is stronger, it's better closure, and it's less effort in straining as well. And in terms of the mucosal wave, it is more symmetrical, and the viscoelasticity is actually really good, and we're happy to see the good laryngeal biomechanics and vocal fold oscillations. So in terms of our outcome monitoring, we measure a series of changes before and after in our patients, and this includes acoustic analysis, aerodynamic with maximum phonation time, perceptual measures with Grobar scale, endoscopic with stroboscopy assessment, and patients report an outcome with VHI-10 and also other throat-related questionnaire as our standard battery. And we see the patient at 1, 3, 6 and 12 months, and you can see on the pictures here is actually pinched from Pigwood's paper, and a similar outcome than we see where there is an improvement in the laryngeal appearance. I'm also good to say that our PRP injections in keeping with the majority of the study, where there is a good safety record and you really can't be allergic to yourself, hence there's no tissue reactions reported. The good thing is no patients have worsening of their voice. We do tell them that they can have minor bleeding or discomfort, and also maybe swelling, discomfort and pain, but rarely airway compromise, and touch wood, none of our patient has that. I thought this showed this interesting case. This is a primary school teacher who is also a choir singer, and she underwent examination under general anesthesia to confirm that she actually has mucosal bridge bilaterally. And you can also see that she has got a pocket from the subcaudal area just below the mucosal bridge. And we agreed that if we find the mucosal bridge that's confirmed, we will inject PRP. She is keen for minimally invasive, less invasive surgery to start, hence why we decided for PRP injections, and because she's also very interested in the regenerative ability. And you can see the injections in the subepithelial layer and within the lamina propria, and that is now filling up into the mucosal bridge itself within the cavity. So this is another patient of mine. She is a retired school teacher and underwent right vocal cord cyst excision about 4 years ago. And you can see this resulted in scar in the right posterior cord. And she's not happy with these because she's a church choir singer, and she's no longer able to have the voice that she recognized from before. So with her, we decided to do a PRP injection, and you can see this is only 4 weeks after. The right posterior vocal cord is already bulked up. She feels her voice is much better, and hence why we agreed to no longer do any injection for now, but to continue to monitor her. And this is an acoustic analysis for Vox plot before the treatment. You can see it's quite hoarse, quite a lot of shimmer, jitter, but post-op this is 6 weeks and everything is pretty much falling within the normal parameter. This is in keeping with her description that her voice is better, and hence why we're happy to keep her under close watch. So in terms of applications in the artistic voice users, we can see that the PRP is beneficial in improving patients' stamina, pitch, and volume. And this is from the symptom perspective. And in terms of indication, we use that in scar, sulcus, and atrophy in our cohort at present. So we are glad that this is making us the UK first NHS centre to launch the PRP service. And from our series, we can see that this is safe, minimally invasive, cost-effective, can be done in the office or general anaesthetic, and the regenerative treatment compared to the existing options are really exciting, and hence why we are keen to see what else is the long-term outcome will tell us. And this is our team looking very excited after our first injection. And thank you very much for your attention. Happy for any questions. And if you're interested, I would suggest you have a listen to Peek, who joined me on the podcast I host officially for the Union of European Phoniatricians. And this is available on Spotify. He will talk about his extensive experience in using the PRP. Thank you again.
Thank you very much for this very interesting presentation, dear Xijing. As we know, after our usual program, we shall have a very good live discussion. And I would like to welcome also to Julian from the United Kingdom, Tom Harris, dear Tom, Ana Gloria from Mendoza, Argentina, hola, Laura Breyer from Vienna, hola, Joseph Schlemmicher-Thier, hello, Joseph, and also Francesco Avanzini, Italia, Jacob Lieberman from Israel and United States, and Deborah Kiadaski from Greece. So welcome, and I shall read a short, very short curriculum from our dear Ismail Kozak from Istanbul, Turkey. As we know, he is a medical doctor, otolaryngologist, specialized in voice disorders and vocology. But he's also a biomedical engineer and homeopath. At present, he owns Dr. Voice Clinic that serves globally for professional voice patients and the one who needs voice care. Also, he owns Dr. Voice Techno AS, a company producing and developing voice-based technologies, including surgical devices and equipments. The technology team has performed successful projects in voice technologies. Currently, his team is developing a voice-based platform called Vocify. He's carrying the voice since 1999 because of his origin as a musician. He's specialized in professional voice and vocal performing arts medicine. And at his one of his duties, he is the voice doctor of Eurovision Turkish team. He's still performing on stage as a vocalist and plays string instruments. And let's enjoy his presentation. Thank you for being with us. Don't leave us.
Dear colleagues, I'm very happy to be here again. I'll make a small presentation about how our facial structures affect our voice. We know that the vocal folds and airway is important for our professional tone and use, but on the other side, we know that other body structures like spine, legs, pelvis has an impact on the vocal use and performance. Voice loss is the absence of signal not only in electrical computational signal processors but also inside of our body by nerves, vibrations and tension sensing and carrying organs like fascia. So the fascia is coming to be a very important topic nowadays. You see a spectrogram of a middle-aged soprano here, and she has a good voice but feels restricted in her high tones. You can observe the dark region at the level of 10 kHz and below. This is a missing harmonic. This fact is taken during the myofascial release session, and when her first overtone filled the missing site, she remembered her severe asthma attack in the college years when she was learning to sing. She suddenly cried and her voice improved after the session. In this slide, this is my student. We've been working on the body and the spectral quality of voice since 2018, and he made his dissertation about it. This is set up with a wearable technology and the voice inputs that correlates voice with body posture signals. Please focus on the overtone quality. And this gave us a lot of idea about how posture affects our voice. This study revealed two interesting results. One, rotational features of body had a great impact on vocal tone. Two, pelvis is the most important site. When we search with body parts or tissue is linked to pelvic motion and the voice, the myofascial lines became apparent as a logical explanation. And after this dissertation, we studied and focused on the myofascial system. Therefore, our study and clinical practice focused on myofascial manipulations and treatments adjunct to our routine laryngological practice. I should say we are so happy with the results. We are using a voice posture analyzer for objective evaluation and practice. Basically, there are 4 microphones that are placed at the front, back, and left and right. It measures the spectral band differences and tags the cursor to show the placement of voice radiating from our body. And the fascial tissue affects mostly 4 to 8 kHz region. This is 3.8 to 8 kHz. A tense fascial block, especially the lateral myofascial line system, has an impact in that range. All fascial lines has different ranges, and this lateral line has 4 to 8 kHz region. You can see the simultaneous recording of 2 microphones. On the left side, 4 to 8 kHz region is higher. We can plot the center of the voice on 2D chart, 2-dimensional chart, and this is a live view. In general, we think that the voice projected voice straight forward from our mouth, but this may not happen all the time. There is usually a polarity to left or right, sometimes radiating to the back. Voice placement is not static, so it changes by posture and use and intention. They both changes the projection line, alignment, and also the polarity of the voice. You can see the angle of polarity from the estimated projection line. Now let's see how it works. This is me, imagine. First, I look forward and phonate with like this. And I turn my head to left and say it again. You'll see the voice placement is aligned with the oral projection. I will slowly turn my head, but the voice overtones will stay at the previous projection alignment. And continue turning my head, so the voice is staying on the left side. The voice is here, and I turn my head, the voice is still here. When I put my head neutral, the voice is still aligned on the left side, and therefore we can control our projection, not by head but with the body. And you'll see it with this device. Let's see it live. In the middle of the screen, there is a white box. This is the room with the subject inside. Blue dot shows the balanced 4 to 8 kHz overtones at 0 point. Left and right side of screen shows a professional voice user standing in neutral posture wearing a mocap device. Now you see, yes. You can see the blue dot. Now he shows the position where he wants to change the put. Yes, he can manage it. Now he's turning his head to the neutral position. He can keep the voice on the right side. Yes, he can easily learn to project the voice to the right side. Now he's showing the left leg. Turn his head to the left. Align the voice to the left side. And he learned how to put the voice to the left side. Yes. So we can control our projection. So we can control either by intention or by body posturing. So especially the pelvic posture is very important. When you put your pelvis, especially the assist region, align the assist region and shove the assist region forward, the voice goes to that side. So therefore the anatomic sites are and the myofascial tension sites are important to voice projection. So therefore what's myofascia is, let's talk about it. We are surrounded by connective tissue in a very, very smart order. And we call this myofascia. This is a thin, though elastic, connective tissue that wraps most structures within our human body. All animals have it also as well. And it's including the organs, muscles, and bones. They form chains all over the body, connecting each other mechanically, like strings of an instrument inside the body. There are 12 myofascial lines defined, but there are also small lines. And you see the bold ones are the ones, we call them cardinal lines. And the one at deep front line with the asterisks you see, it's the most important. Our larynx and vocal cords and all phonation organs are inside this deep front line. This is a schematic presentation of anterior and posterior superficial myofascial lines. Both are imbalanced and connecting acoustic regions with tension like sound bridges. We can easily assume that their string-like analogy has impact on voice, but not only on that, it also affects the laryngeal behavior. And this is a male larynx. In inspiration, we he will carry a load by bending forward with a poor posture. You can see the tight closure of larynx because the larynx works as a closure of the airway, so our lungs becomes like airbags. So it helps the posture. It gives us some power to straight apart. So the system is working for posture now. Just focus on the triangular shape here because this is very important. When the larynx is used for posture, so its behavior changes. While carrying a load with poor posture, his breath is like a whisper. This triangular shape posture remains here. But when the posture is aligned and the load is evenly distributed on the pelvis and homogeneous fascial load, the vocal folds stays parallel. So the laryngeal behavior changes. This slit produces the jet flow of the breath that is perceived like a flute tone. We name this as inner flutes. And when the inner flute starts, it's about 1.6 kHz peak after scalene fascial release. 1.2 to 1.8 kHz frequency is measured depending on the size of individual. This frequency corresponds to F6 fa note. Do myofascial system pathologies affect voice? Yes, especially when the painful sites, tension regions, range of motion restrictions, hydration problems are mostly observed. There are currently a lot of papers are increasing in number. I'm not sharing all these cases. I'm trying to present my experience in the myofascial release conditions. And what does it cause? What's the vocal effects of it? It causes impaired perception of tones in the body, impaired projection of tones, measurable acoustic changes, perceptual acoustic deviations from the body. And what is myofascial release? It's relaxing the immobile and painful fascial segments by manual or medical approaches. We laryngologists are not manual therapists, therefore pain management and control of inflammation is our main focus. However, a voice clinic running with a team including manual therapy sounds valuable in terms of applying fascia therapies. A study in 2018 Journal of Voice showed how important the massage therapist in the patient's choices. So we do myofascial manipulations and release techniques not only for flexibility and pain suppression, but also for performance and emotional balance. Let's focus on the steps that we apply in our routine clinical practice. We name this technique as somatoacoustic therapy. We take patient to a silent and dimmed room. The patient lies supine. We find the tension signs manual and limited our range of motion regions. We apply light or moderate touch on trigger points in 20 to 60 seconds. The patient inhales and exhales freely. When release starts, breath tone turns into a flute quality. After the tone is stabilized, we tell the patient to phonate in the same note of that flute. When breath support is better, overtones becomes apparent. To enhance the overtones, an instrument such as a piano used to give major or minor seventh chords. After we enrich the full spectrum, the tone is carried to the other notes, scales, and vowels. This is a patient laying supine, has connected abdominal breathing through mouth. Jaw is open 1 centimeter wide, and we activate the deep front line by breathing. You see here? Just focus on the breath tone. Inhaling, inspiration, and expiration tones are different. When we find the tension site and start releasing, the inspiration expiration sounds becomes equal. It's a bit of different sound. You focus on it. You focus on the breath tones. And we find the flute tone. And after the flute tone, we voice inside the fluty tone. Each fascial line specifically influences the spectral frequencies. And you can see the different sides. For example, this is lateral line. It increases the 4 kilohertz. Fascial release also improves the lower frequencies. And myofascial release below the hip down to the foot enhances the highest spectral frequency. If you imagine the body, the lower frequency is in the highest part, near to the head. When it goes down, the highest frequency starts to appear. During the session, it's beneficial to familiarize the subject with overtones by overtone-rich instruments. We use the sound of this video. And we follow the patient's nose. During the interludes, after the voicing, the patient produces a note. We do not change the note. We just align with the note and take the note from the patient. For example, this patient produces a C note, and we give C minor 7th chord to enhance the coordination between the somatic note and the auditory perception. This is a simple diagram showing frequencies affecting the body parts. This shows the release points and frequencies affected in somatoacoustic therapy. You can see every part is a different frequency response. And let me share 2 cases. This is a low view who experienced a voice loss after a stressful condition.
1, 2, 3, 4, 5, 6, 7, 8, 9.
And she already has a MTD type 1 and a mild Rhine keys edema. Let's focus on the because her chink is very and immediately after the session, let's listen to her voice.
1, 2, 3, 4, 5, 6, 7, 8, 9.
Let's see the closure. Another patient, this is a case with granuloma. He took 3 sessions between 4 weeks apart, 1 month apart. 1 month after first session. Second session, 2nd month control. And he is still free of granuloma after 9 years. And as a result, in a conclusion, myofascial tension affects inner and outer radiation of voice. Myofascial release improves the perception of harmonics, boosts body placement and projection, has a positive psychological effect. Thank you for listening.
Thank you very much, Ismail, for this very interesting presentation, and I am sure we shall have a very good discussion. Thank you, Ismail, and thank you to all. And now it's the time to present our fantastic new members 2026. First, Dr. Leslie Childs. She presents herself. Let's hear her.
Hello, everybody. My name is Leslie Childs. I'm a laryngologist and professor at UT Southwestern Medical Center in Dallas, Texas, United States of America. And I am absolutely thrilled and honored to be considered a member of the Collegium Medicorum Theatri organization. It seems that this organization is filled with some of the absolute legends in this field. Lucky me to be a part of it. I was asked to create a video to tell you all a little bit about myself. So I will begin with growing up in Austin, Texas. I have always loved singing. And actually, when I was a teenager, decided I wanted to pursue laryngology as a career, believe it or not. I went to Yale University for undergraduate and then medical school at Vanderbilt in Nashville, Tennessee. And I stayed there for my otolaryngology residency at Vanderbilt, and then pursued my fellowship in New York City with Drs. Andrew Blitzer and Lucian Sulika. Ever since then, I've been here in Dallas, Texas at UT Southwestern. I'm the director of our voice center. We have 2 other laryngologists with whom I partner and 6 voice therapists. And I'm now entering my 15th year there. Most of my practice is made up of singers and professional voice users. So I'm fortunate that I have been able to pursue my dream of caring for singers. We have a well-established connection with the major performance venues in the Metroplex. So we often will care for the touring artists and professional singers who come through Dallas, as well as Fort Worth. We also partner regularly with the several music schools surrounding the Metroplex. We will often give vocal health lectures and provide stroboscopy screenings for especially our younger singers who are pursuing a degree in vocal performance or music education. And along the way, I've also been fortunate to be able to study our injured singers and really create an impact in terms of being able to better counsel our singers regarding expectations following injury. We know that, for example, many of our singers with phonotraumatic vocal fold lesions actually do not require surgical intervention given the reversibility of many of these phonotraumatic changes. So I'm hopeful that that has helped to create an impact and better care for our singer population. Moving forward, I look forward to collaborating with all of you as we care for this unique population. And I thank you so much for the opportunity. Have a wonderful day. Bye-bye.
Thank you very much, Leslie. And I thank all the COMET members that voted on time for our Leslie. And she is keeping on with the great tradition of Texas with Dick Stasny, Austin King, and some other colleagues. Thank you very much, Leslie. And now I give the time to the presentation of Xi Jinghei. You also voted for her, and we are really very happy with both new COMET members in our COMET family. Thank you, Xi Jing.
Following my talk earlier on the PRP, thank you for the time again, Eugenia, for a short talk to introduce myself. And for those who haven't heard earlier, my name is Xi Jinghei. I currently work in Guy's and St Thomas's Hospital in London as a consultant ENT surgeon and laryngologist. A little bit about myself. I come from Malaysia, which is a small country in the Southeast Asia, a bit further from London, about 12 hours flight. And this is the small town I grew up in, which is on the Strait of Malacca. And it's a small town just on the west side of Malaysia. And this is my school, our town, very beautiful port town, very peaceful and calm. For those who haven't been to Malaysia, I highly recommended it. It has got a variety of landscape, particularly with nature, where there is beaches, there is limestone cave, mountains you can climb, and lots of activities. And of course, I love to call it as my home. After finishing my school in Malaysia, I went to Edinburgh to do my university study. And the picture you see on the far right, that is 2 skeletons of dinosaur. That is the entrance to our medical school lecture hall. So we have to go through that every morning. And I currently work in London, and this is a skyline of London. That is the Shard. And we are a little building next to the Shard. That's where our hospital is, Guy's Hospital. So if you ever come to London, do give us a shout and come and visit us. In terms of my clinical background, I trained in the beautiful Scotland, where I have the fortune to train in a variety of places in Edinburgh, Dundee and Inverness with excellent trainers. And in Scotland, if you haven't been familiar, this is a skyline of Edinburgh as a city. And on the left side, there is lots of activities you could do in the Scottish Highland. And also, if you're interested, you can go and watch the Scottish Highland show where men are doing all sorts of sports activities in the Scottish kilt. So after 6 years of training, I then went to London in 2022 to do my fellowship with Yakubu Karagama. I'm sure many of you would know him personally, and great mentor to have. And I couldn't be more happy that he is my fellowship director as well as my mentor. I then graduated following the fellowship because this is a Royal College of Surgeons recognised fellowship. And after that, I went on to do a few travelling fellowships. First one was in Rouen with Professor Jean-Paul Mailly. Many of you would have known, and this is in the town of Rouen. Unfortunately, the church is slightly damaged now after the fire, but this is how it looked when I was there with Professor Marie. And that's us, just in December last year, where we were teaching together in Bali on reinnervation surgery. Very grateful for him to be a good teacher to me. I also went to Boston and did a month with Professor Zeitels, and very grateful for him and his team to welcome me at his Voice Health Institution, where I learned lots on elite performers and also phonomicrosurgery. There's lots of things I've taken away from that I will be benefiting from it for my ongoing career. My current practice, in addition to voice, I also do swallowing and airway. I run a voice clinic regularly, and this is in a multidisciplinary model joined with our speech therapy. We also have a dedicated performers and artistic voice clinic. And in here, we don't only see patients, we also do office-based laryngology, including laser, injection, laryngeal EMG, PRP, biopsy, airway, and cricopharyngeal balloon as well. I also have a range of phonomicrosurgery that I do for the patients we see, and also interested very much in laryngeal framework surgery. And this is a patient after type 1 thyroplasty, and as you can see, for a vocal cord paresis. And because of the travelling fellowship I had before with Professor Marie, neurolaryngology and laryngeal reinnervation surgery is always something that is quite close to my heart as well. I'm also spending some time on the academic stuff, and with publications, over 30 book chapters as well, and oral and poster presentations. And currently I'm chairing the scientific committee with the European Laryngology Society on the HPV consensus paper with occupational health risk, and look forward to sharing this with you all soon, and also contributed to the office-based procedures paper. I'm very keen on teaching and training with a background as a faculty of surgical trainer at the Edinburgh Royal Surgical College, holding a postgraduate diploma in clinical education as well as honorary university lecturer. I'm currently the director of the Young ELS Mentoring Program, so any of you who are ELS member, do sign up to be our mentor. I also actively participate as a mentor in various organizations and supervising our residents and fellows. I'm also very much enjoyed teaching at various phonosurgery courses, both locally, nationally, as well as internationally, and sharing the love and passion in laryngology. There are also international education initiatives where I host the official podcast for the Union of European Phoniatricians, available on Spotify. And very recently, in last year, we launched the Artistic Voice sub-series, where we now have Lance Marrant and Kitty Verdalini Abbott as our guests on the Artistic Voice. And this has now got 11 episodes, 13 guests, and we are also very pleased to say that we've been listened in more than 70 countries. I'm also very keen at promoting laryngology to the wider audience through our annual ELS live surgery broadcast, where I join Yakubu with that, and also very pleased to be invited again to the UEP Voice Marathon that's happening this year in April. I hope I'll be able to contribute at the Comet by supporting the advancement of artistic voice, contributing to the related education and clinical progress, help raise the profile and visibility, and also hopefully strengthen the interdisciplinary and cross border collaboration, the fact that we've got such a wide membership from across the world sharing the same passion in artistic voice users. Thank you very much. Very happy to be contacted.
Thank you very much, Xijing. So as you see, dear friends, Leslie and Xijing are wonderful, wonderful Comet members now, and they have a great trajectory. And of course, they are sharing the same ideals as Comet family. So now let's go to some of the general information. Don't forget, we need your information for the web page. This is important if you want to send your photo or a short curriculum or your datas, because as we know, Comet family is an international family, and we do need all the details when we need one of our patients or performer needs to go somewhere else in the world, that we have the same position as Comet members. Next one, please. And of course, I remind you that I am waiting for your topics for the World Voice Day. Don't forget the World Voice Day celebration, also from Comet, is for the general population. I have already some members that send the topics, for example, Liza, Ray Yasaki, myself. So please do not forget, send your topics, and we shall have, as always, a pre-recorded celebration of the World Boss Day. This is the contribution of Collegium Medicorum Theatri, and this will be our 27 online session. The next one, please. And then we shall have of course, don't forget that we are some of the most important experts in the world, and we are contributing with discussion, with scientific and artistic point of view to the development of art and science in performers. Next one, please. And our next important date is the 28th online session. We are going to talk about superior laryngeal nerve surgery diagnostic treatments. And please, if you are interested or you want to share something, please let me know as soon as possible. The next one, please. And the webinar artistic voice that we make traditionally, it will be 5th of September, and it's care of the artistic voice professional. And for example, there will we have the Liza Popale contribution about touring performers. This is interesting. But send your topics also. This is also for all the public. It's of course it is scientific and artistic as Comet all the time does. The next one, please. And I would like Katrin Neumann. Bist du da, Katrin, dass du kannst uns was sagen? Perhaps Katrin can make an announcement. Katrin, are you there, dear Katrin? Yes,
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 I'm
no?
there. Yes,
Yes.
yes.
Oh, wonderful,
Um,
please.
yeah. Um, we can you hear me?
Yes, perfectly.
Can you hear me?
Yes.
Okay, great. We would like to invite you, my team and me, to come to Münster by the 1st October of this year to the 4th October for the next Comet conference. It would be really my pleasure, and I can at our next meeting, I can make a nice presentation about Münster as a conference place. We will have very good venue and musicians there also. My only problem is that I realized that we have a lot of conferences this year. We have the PIVOC in April. We have the IFOS in August. We have the meeting of Josef Schlümicher-Thier in Salzburg. It's also August. No, IFOS is September. then we have our German conference 1 week before this COMET conference. And so I would like to ask you all whether this is a good time, 1st to 4th October. There is another opportunity 2 weeks later. So maybe you think it over, and I send an email to all of you. And it could even make sense to later. Yeah, I see what Stan writes. Or could even make sense to have the conference next year. I do not know whether this is possible because of our rhythm. Yeah. What do you
Well,
think?
thank you, dear Catherine. We know exactly in the communications society that we have many conferences, workshops, and meetings. And also at home, we have many things to do. But I do think the annual conference is very important that takes part now in Münster in Germany with you, because you and your group are very important pillar in all the development, not only in communication with voice and artistic voice, but also with hearing. So I do think that this date is very nice, for example, because of weather, because of traveling. And in October, we do not have another appointment. So annual conference, COMET, is COMET family. It has to be social, cultural, academic, scientific. So I invite everybody. And personally, I do agree with 1 to 4th October. And I hope if somebody has some things, please let us know. But I thank you in advance, dear Catherine, for this announcement and this possibility that you host us with the great Dome in Münster. Thank you very much. So the next one,
It will be
please.
our pleasure.
So I would like to share with you, dear friends, that the conversation Artistic Voice Specialists Inform in this PVOC, Pan-European Voice Conference Voice Istanbul, will be in the Hall 4 on Thursday, 26 March from 8:30 to 9:30. Next one, please. And the program is already done. So we are going to have first of all, expression codes in singing by our dear Comet honorary member Johan Sonberg, vocal damping, history, philosophy, and new perspectives from Marco Fantini from Italy, the assessment, the performer's voice, a wild goose chase for acoustic equivalence, or redefining the goal from Pedro Pestana from Portugal, the challenges of maintaining a performance voice in idiopathic stenosis by Julian McClashan from United Kingdom, and the effects of a hypertonic saline nebulization on voice quality, literature review, and pilot investigation from Ana Danik from Croatia. So this is a great program, and I am sure you will enjoy very much PVOC 16 Voice Istanbul. I'm sorry that Ilter is not here, but we make the announcement that everybody is coming to PVOC and Voice Istanbul. And I am sure Comet Session will be, as always, a great performance from Comet family. Next, please. And of course, we shall have the annual symposium. This year, we shall not have a Comet session, but there are many Comet members taking part of this very important Voice Foundation symposium. Next year, we shall have our special Comet session in the Voice Foundation. And now, Joseph, I give you the word. You invite us, please, Joseph.
Yes. Hello, everybody. We have our next Salzburg Symposium in August 21 to 23. And it is a celebration of my 30 years work in Salzburg at the Salzburg Festival. So I invite you to come, and I think you will enjoy the Salzburg Festival. And soon the program is coming. Again, you will send out. And
yes.
Thank you.
Thank you. And I would also like to comment, because Joseph was so kind to send to me this letter from Rolando Villazon. Rolando Villazon, as you know, is from Mexico City.
Yeah,
He used to
yeah.
be my patient when he was in Mexico. Now he's Joseph patients and some other Comet members' patient. And well, he wrote a very nice letter to the symposium, Voice Symposium Salzburg, Voice Care on Stage Festival in Medicine. Thank you, Joseph, and I am sure you will enjoy that very much. Thank you, Joseph. The next
Thank
one,
you very
please.
much.
And well, some things to remind you, the exchange knowledge and ideas among the members in the forms of seminars, meetings at international or national conventions is very important. If somebody wants to have the approval from Comet, please let me know, because, for example, we give the support, academical support to La Voce Artistica, to Salzburg Festival, and to many other friends from the Comet family. And as you know, a member who is willing to organize Comet Congress, like this time, Catherine Neumann, and in 28, Pedro Pestana in Porto, in Portugal, needs to submit his or her proposal to the board at the General Assembly. Thank you. The next one, please. And of course, it's very important that I encourage you to give lectures dealing with artistic voice at other congresses, but also to our online activities, because we do know we have some technical problems. It's okay. It happens all over the world. We are maturing and maturing and trying to do better and better, but we are completely conscious that sometimes the technical situation is not what we would like. But anyway, please be sure that your contribution will be great for all the world, because we are one of the associations in this very special communication field in performers' voice that have so many upload in YouTube. We have all the sessions there, and it's great to see all the great contributions that you have made. Next one, please. And of course, I do remind you that we need to be active and be present every 3 successive annual meetings to maintain active status, also to present, to be online, and also please don't forget the fee. We had some troubles with PayPal, but now you may pay the fees. Please, I remind you, the 3 last years you have to be active. You need to pay your fee. Thank you very much. And the next one, I do think that if somebody needs to give some event or some legacy, please let us know. Austin King is preparing the history of Comet. And of course, we have many, many things, photos, presentations, and of course, the great membership works in our webpage. Don't forget to look at that, because it's really great job from our dear Professor Jürgen Wendler and from many, many of our dear Comet members. Next one, please. And of course, the rights and obligations. Any member can present her or himself as Comet member after the approval, but this is important because Collegium Medicorum Theatri members belong to many international and national associations. And as we decide in last General Assembly, we can invite everybody from our clinic, from our friends, from our patients to be in this Comet online session. And of course, they can come to Münster to Dr. Professor Katrin Neumann and Philip Mathman. And of course, the right to vote at the General Assembly. We shall have the General Assembly in November, also online, because it was decided like that. Next one, please. And well, enjoy Comet activities, invite your group. And now we shall make the photo. Please open your, and we stop the presentation, and then we have the live discussion. And then we can have our photos. Please, Karina, make many photos. Our dear Ron has only audio, but we do enjoy your voice, dear Ron. And of course, we had some other guests like Seher Siri And well, welcome to the new members. And I really enjoy being with you, all our Comet family. And dear Sarah, I'm happy to see your face, my dear. Thank you. And thank you very much for being here. And so we close the session and then we begin with live discussion. So let's begin with our dear Xi Jinping. So somebody from the audience would like to ask something about Xi Jinping very interesting presentation? Yes, Catherine? Yes,
Yes,
Catherine?
yes, Xixing, I wanted to ask, you mentioned 2 milliliters you inject in each vocal fold or in both together? 1 milliliter or 2 milliliter per vocal fold? And how deep do you go? Because he also mentioned subglottal, but I haven't seen that. Yeah.
Yes, and so not sure if I said subglottal maybe by mistake, but usually, no, I don't inject in subglottal, but you're right to say that because the vocal cord is not a very big place. So usually our protocol is you either inject until the extrusion of the material, because that means the layer you're injecting is already full, or until they meet in the midline. Usually, although you would worry whether this would cause any airway problem, but actually, none of our patients do. And it is very interesting to talk about the site of injection because I had a lot of discussion with Peak Wu about these, as well as Hirano, because he also did a lot of work on the regenerative site while not necessarily using PRP, because in Japan they have completely different material, which is commercially available only in their country, but not outside. So the regenerative ability is thought to be, it depends where you want to inject, as in where you want to regenerate. If it is muscular atrophy, we tend to inject within the muscle itself to encourage the bulk. And that can be within the paraglottic space because the PRP is quite viscous. So it goes everywhere actually when you inject, number one. And number two, but if you were to treat, for example, like a scar or a sulcus, where you want to have it lifted up from the ligament and you want that layer of lamina propria to regenerate potentially, then I do make sure it is also within the subepithelial or anywhere that is where the adherence is. But yeah, usually it really depends on the pathology. It's either paraglottic or subepithelially, and it is until whether it extrude or they start meeting in the midline to be deemed sufficient.
Thank you, Xi Jinping. Yes, Antoine, you wanted to say something?
You
Antoine
didn't
Giovanni?
say 1 or 2 milliliters.
Yeah,
1 or
doesn't
2.
take much. I mean, until either it comes out or it finishes. Usually 2 mil is more than enough. We wouldn't be able to put in more than 2.
Okay.
Thank you. Yes, Antoine?
Thank you. Basically, I've no question. Just I wanted to congratulate Dr. Singh Yi for this very nice presentation, and welcome among the world of PRP doctors all around the world. It's a PRP is probably the easier way to enter the vast domain of regenerative medicine. Besides growth factor, as you mentioned, in Japan, and besides stem cells themselves. In my opinion, I must say that I am not very convinced by the effects of the PRP to augment the volume of the vocal fold, and probably in this case is when there is some tissue missing, an atrophy. It's probably better to simply inject hyaluronic acid. But in case of mucosal rigidity, as you have shown in sulcus and scars, PRP is a very, very good tool. Probably that doesn't work more than in one case every two, but there is no other solution. There is nothing else to do. It's better than 50% is better than 0%. and it's repeatable. It's very easy to inject. I think everybody must try it. It's a very simple solution for this case of moderate dysphonia and aging voice, for example. There will be a session in PEVOC, in the next PEVOC on regenerative medicine, if you're interested.
Great. Great. Yes, Dick. Yes, Dick.
I enjoyed Dr. Hayes' presentation. I'd give you a little sidebar. About 30 years ago, I got a call from Krzysztof, and he wanted me to give a presentation at the Pacific Voice Conference about fat injection on laryngoplasty and Gore-Tex thyroplasty. And he said, "You got 10 minutes." And I said, I put on my North Texas accent, and I said, "Well, Krzysztof, I'm from North Texas, little town called Albany, and I can just barely get my name out in 10 minutes." Anyway, he let me go ahead and give a talk and gave me 20 minutes. But using fat was very similar results, except that they're more long lasting. And the patient winds up with a little scar in the greater trochanter area, which they've never complained of. I did about 450 of the injections, and they never complained of the scar in the greater trochanter area. So I highly recommend that. One patient got an injury to the neck and got a CAT scan of the neck 14 years after the fat injection, and you could still see the fat in the vocal fold. So it does tend to live in there. And so I think I did it for sulcus, I did it for atrophy, I did it for presbylaryngitis, I did it for many reasons. And it seemed to really help the voice. I even did it in a couple of boys that were 20 years old and still had puberphonia, and had speech pathology for a couple of years and didn't improve, and they had a sulcus as well. So anyway, that's an alternative to your technique. I used to centrifuge the fat, and then basically it was very difficult to keep it sterile, so I put the fat in a urine strainer and then washed it with Physiosol. And I washed all the platelets and the lipids and the blood off of it. So the good stuff that you were talking about, I had eliminated, but just the pure fat went in. And I used to inject until the anesthesiologist said, "Whoa," and they got a little nervous because they could see the vocal folds coming together. And fortunately, out of 450, I never had an airway obstruction from it. But anyway, it's an alternative to that. But I loved your presentation. Thank you.
Thank you, Dick. Yes, I also agree with Dick and of course with Xijing and Antoine, because I usually inject fat, autologous fat, and I have great results. And as you know, I have more and more confidence, and I am very happy with local anesthesia, but also with IV sedation of the patients, because I do think when you have this stroboscopy, like I learned from Jürgen Wendler and Wolfram Seidner, well, it's great because you can see exactly where you are injecting. And also, I was thinking of perhaps I shall try in the next patient to combine both techniques, because we don't lose anything. And about hyaluronic acid, I am still a little bit skeptical. I prefer to use as natural, as autologous as possible material. And Ron Scherer is asking, how do you know, Xijing, regeneration has taken place? Yes, Ron, thank you for your question.
Yeah, thank
Yes,
you for
Xijing.
the comment and question, because for what Antoine said about the hyaluronic acid, these patients, we used to inject hyaluronic acid actually for the atrophy patient. We still do. And we are starting to use the PRP because thinking that obviously it is, as Eugenia said, it is cheaper and it's patients owned. And the worst thing is it doesn't work. And a lot of the study actually stemmed from Hirano study because, you know, in Japan, people probably live forever. They have lots of atrophy patients with their vocal cord because of the aging population. So they have done lots of work in these. And we have got some patients that work, but we want to see, I think the very important question is, does it last? Because Probably short term it does, but long term, how much do you have impact? But again, if it's repeatable, so if you do need it, then obviously patient's blood is free, you can get it. And also with the what Dick was saying about the fat, very interesting because we are now exploring. Pete was doing a lot of it as well, is nanofat, which is similar to the idea of the fat being a regenerative. And nanofat is liquid, actually. So our machine that we have recently purchased not only can generate PRP, but that is the next phase we plan to try to see whether nanofat will also have the same impact. So yeah, we will probably come back next year and tell you more about it. And on what Ron said about whether how you know regeneration work, if you're asking a microscopic level, we don't because we won't be able to tell. But very interestingly, with all this regenerative, across all the people who do them and report them, you tend to find patients tell you it is improved before you get endoscopic or acoustic or even perceptual improvement. But patient tells you they are better, particularly with the phonatory effort and also the pitch. But what you measure may not necessarily be that sensitive to pick up, or even stroboscopy, it might lag behind. So I can't tell for sure whether it regenerates or not, but so far it is a big debate at the moment. But Jackie Allen just in New Zealand just published a paper and said, while a lot of people do 3 months, three injection 1 month apart, which is more like an arbitrary setup, we now go with what the patient feel. If they do get improvement after one and good enough, and we just do nothing and watch it, and we want to see whether that will be sufficient rather than going all the way. But patient with more severe scar or severe dysphonia, we tend to say, why don't we go up to 3 and then see what happen after? So yeah, this is something that we don't really have full answer yet, but look forward to telling more about it.
Thank you. And also, I would like to comment that it is important, for example, in our patients in Mexico City, we do inject fat, but we do also with the special language pathologists with voice training in order to improve many things. Because what the patients that we have injected in the last times, they are really very difficult cases with stenosis and many other things, and they were. They improve in volume, not only in frequencies, but in volume. And this is important to work all together in multidisciplinary team. And I would like to say, Philippe, if you want to say something about your very, very close relation to Chris, because Chris was motivating everybody. Please, Philippe, do you want to add something?
Yes. Do you hear me?
Yes, perfect.
Okay. No, I explicitly wanted to limit to, let's say, the scientific work of Izdebski, but of course, beside that, but that Austin and you yourself told it enough. Krzysztof was a very good friend, a noble person, and of course, on the human level, he was still more than on the purely scientific level. He was really a great person.
Yes, and he, because he was in California, and as you know, California in the 18th century was Mexico. He all the time spoke Spanish to me, and I have a picture talking uno, dos, tres, 1, 2, 3. But anyway, we have great memories from, and I thank you all because we wanted to make a special tribute to him. And well, talking to you, if you want to add something to the presentation of Xi Jinping, or we go to the other question with Ismail. Ismail, when I first saw your presentation in Antalya in UEP, I was really very happy because through the time I was developing dynamic exercises for voice therapy. And the dynamic exercises that I developed were exactly moving the body and moving the head and making some efforts with the arms and the shoulders. I have been presenting these dynamic exercises, but many of them are closely related with your topic. And so I do think this is myofascial is very important. Also the release. I don't know. I want to congratulate you also because the presentation is very well done and very clear. And of course, we need to make the contribution to the active and dynamic voice therapy. And of course, I was thinking, this is my question to you, Ismail, what happens, for example, with the performer that also needs to make some bodybuilding or exercises because they have uh, another kind of exercises with tension and with less flexibility but more power. What is, in your experience or your knowledge, about performing and releasing the myofascial, and on the other side about having this physical training for being in more shape?
Yes, thank you, Eugenia, because I'm very happy to be again. I couldn't hear myself during the presentation. Could you?
Yes.
Oh, great. So
Perfect.
that's then my computer is slow. So the myofascia, I met myofascia in 2018. I was doing a lot of thyroplasties at that time. I mean, I was doing voice deepening surgeries, especially in the deepening patients, but there was a problem with the deepening patients because when we get lower in the frequency, the patient had the problem to stabilize their frequencies. They were away from their new low frequency. So therefore, I realized that they are difficult in placing their voices. So in order to encounter this problem, I tried to search for if the body has an effect or if there is a default in their mind, a fixed in the frequency, if it's a default frequency. So I started working with the guys, with my students, and they designed the device, and we could measure which posture effects, which it was very interesting. The highest frequencies are mostly affected by the myofascial lines, and they are very connected, they are very linearly related. Especially, there are two lines which are important. Which one is the lateral line, which comes down, which starts from the foot and goes laterally and goes up into the temporalis region, and its effect on the voice is 4 to 8 kilohertz level. So it provides a asymmetry. Sometimes we can polarize our voice, and we can speak to right side, we can speak to left side, and the tension is affecting it. When there's a tension in the other side, the high frequencies shift to the other side. So therefore, we can measure it. You saw, I tried to show the device, but I couldn't watch. I couldn't answer. For example, if you want to sing to right side, you can sing to right side. If you sing to left side, this is external placement. But we have another problem, that the internal placement. I mean, a chesty voice, a sacral voice, a deep pelvic voice, and we don't talk about them mostly. And after I started working on myofascia, I started to see everything in myofascia. It's very interesting. I think that the vocal cords are myofascia. They are sheerly vibrating. There are two types of myofascia in the body. One is the tension vibration, the other is the shear vibrations. So therefore, vocal folds are the very, very same structure as the myofascial system. So therefore, it has its similar rules of the myofascia. After we start doing the myofascial treatments, and there came another problem, that how we could manipulate it, because so we found out the slings. There are some slings that is effective in the voice. For example, the chin sling and stylohyoid sling, sternocleidomastoid sling, and scalene slings. And when we work on them, the voice quality really, really changes and it becomes persistent. Second, myofascia is a very important thing. That's the emotional part of our body. It carries the emotions, it carries the history. And so therefore, when you release the patient, the emotional things comes out. and the voice therapy becomes a little bit something different, and you have the chance to talk about what happened in the past related with the voice problem. And the most problems goes backward to the learning period. For example, in professionals, they usually have trauma in their learning periods, in first years of the college. So when you talk about all these things, you become a little bit integrated approach. The voice gets better and better. You treat emotionally, you treat physically, you treat the voice quality, and the rules are a little bit different in myofascial voice therapy. And in November, there's a paper in Laryngoscope that says that voice therapy is very good. We do the voice therapy always. And we do the medications, but when we add myofascial release with the voice therapy, the results are amazing. So we start working on myofascial voice therapy techniques, and the rules changed a little bit. For example, imagine when there's a certain note, for example, in your profession, when you go a very high note, you feel some tickling sensation and you start coughing. We think that this is a problem. Actually, in myofascial therapy, it's not a problem. It's the transition of voice. It's the emotional part of voice. So therefore, I think it's a new kind of therapy that we should work on. And the therapist should be a physiotherapist or a manual therapist, but should be familiar with the tones, because you're dealing with the overtones of the patients. And you should be familiar with the notes, because the scales are mostly overtones of the major seventh, minor seventh chords. And you get the note from the patient, and you sit on the piano and you give the overtones, and you work on the overtones, not the fundamental frequency. So it's very interesting therapy. And in PIVOC, I have 2 hours of session, and I'm going to do manual not as a lecture, but I'll try to show you how it works. So I think it would be beneficial. I'm very excited in presenting this because I love it. And last weekend, I made a voice camp. It didn't finish because it's a very, very big topic. It's a really, really big topic. And we're giving lectures every month on Wednesdays, about 2 hours, and it takes about 12 weeks, so it's long. So the theory and the behind it, and the applications, and the mind and the body and posture in professionals. For example, in myofascial therapy, the functional lines and the arm lines are the expression of our body. Imagine you have mimics, and when you change your mimics, your voice changes. And you have the body mimics with your arms and functional lines. Your body mimic changes, and it also affects your voice. So these are all the acting problems. So I think I'm going to give some lectures on it, and I'll be happy to share with you.
Thank you. Thank you. And somebody from the audience want to say something? Liza, you have some comment? Ron?
I'm
Yes,
just very
Liza.
interested to learn more. Ismail showed me some basics a few years ago in Altalia, and I have a lot to learn. But I really like to do more of the hands-on, especially when they're regarding the holding of the pitch and how the holding of the pitch is diagnostic. That's particularly fascinating to me. So I look forward to spending a little time with you in the hallway or on the floor of a quiet room, and you can do your thing. And I'd really like to explore more about the diagnostics.
Okay,
Thank you. Thank you. And somebody from the audience want to say something? Well, I really think, for example, joining all what we have learned about osteopathy, and of course about dancing, and all these dynamic exercises that I develop with the band of exercises, and also because in the modern stage they do want particularly very good presence and and the performers need to make a lot of gymnastic and things like that. So I think we are coming to a point where all the disciplines trying to make understanding the body machine, we need to learn from each other very much. And also the individuality, because we think of muscles, bones, myofascia, and ligaments, but also every person is a little bit different. Not everybody is the same. And also I wanted to ask you, Ismail, if you have some experience with temporomandibular joint and with temporal muscles, because as we know, all the muscles in the head also, and of course in the mouth, have also a component in the voice production.
Yes, yeah. I mean, temporomandibular joint itself is not a problem, but the muscles and the fascia in the temporalis region is very important, because the temporalis muscle and medial-pterygoid muscle and masseter, and there's a new muscle called coronoid muscle. It's very newly found in it's defined in 2023. I'm sorry, 2022. And it's very important because this muscle limits the mandible position, and it has an effect in the postural, I mean, forward and backward position. It affects voice very much. For example, when you release it, you open the harmonics. So most of the patients have bruxism in Turkey. And the bruxism is a kind of expression of a kind of the protection or a kind of anger and emotional body part of our body. So therefore, when you treat it with emotionally and with the release techniques, the voice opens up too much. It's very good. For example, when you have I mean, limited chin, so you don't produce a very good voice, but it's relaxed and it's open, you produce very good tones. But it's all linked together. When you release the chin, also you should release the stylohyoid, you should release the omohyoid and scapula, etc. It goes all the way down. So myofascial system is like a chain. It is not a simple muscle group, and there is always some connection with each other. If you follow this connection, you make a, first of all, ampolar, a straight projected voice, and also a very relaxed and the emotionally well developed voice. Microphone, Eugene.
Can I ask a question?
Yes, please.
Is there much, because when you apply myofascial aspects like you have discussed really so interestingly, and there are acoustic and physiological changes that relate to sound production.
Yeah.
Has there been much EMG, electromyography, or vocal tract scanning in order to try to determine what the physiological and acoustic correlates are, how they depend on each other?
Yeah, this is, for example, myofascia is not a muscle. It's the tissue surrounding the muscle. So therefore, EMG, we use EMG, for example, for coronoid cases.
Well, may
But it doesn't
I interrupt you a second? What I'm referring to is when the acoustics change and different harmonics come into play, there is probably a change in how the laryngeal system is operating relative to adduction, could be also respiratory. And then there's also when you are you showed spectra that differed in intensity in certain frequency regions, often quite high in frequency actually.
Yeah.
There should be vocal tract cross-sectional area function differences. So there should be a source change at the laryngeal level dependent upon muscle action of the intrinsic laryngeal muscles, as well as vocal tract changes as you manipulate the fascia. And so this is the question: how do we get from myofascial aspects to the acoustic aspects via the physiology at the laryngeal level and the vocal tract shaping, which is also physiological?
Yeah, thank you, Ron. It's a very good question. It's my major question during the workouts because I observed the voice change, but at the same time, we measured spectrographically. When we release the tissue, the spectrogram is open, all the therapy sessions, so we can see the increase and decrease of the frequencies. So that gives us some idea which part of our body is affecting which part of the myofascia. Secondly, there's a critical point here that I call it inner fluids. It's very interesting. It's really, really interesting. When you come to inner fluids, it's almost in the F2 level. And it's about 1.4 to 1.6 kilohertz. The laryngeal behavior changes. We measured patients while with posture problems and while they are holding a heavy object. The laryngeal system behaves differently. When you put in a straight posture, the laryngeal behaves something different. Larynx, as we know, that it's a swallowing organ, it's a breathing organ, voice, but it's also a posture organ. If you have a postural problem, the lungs behaves like an airbag. So how do you control this airbag? You take breath and hold it, and you work with it. So you hold breath, and while doing this, the larynx behaves like a triangular shape, like this. But when you have a good posture, the vocal cords come into a parallel posture and produce a fluty tone. It's very interesting. We do this technique when the patient is laying down. And when the patient produces the flute technique, it's almost at the same frequencies. So this is the first progression from breath noise to a periodical signal. And breath is a noise signal, but you also have flute tone, and it becomes a periodical signal. I mean, it develops from noise to the harmonics. So at that time, we use this harmonics to develop. So it's our reference to help the patient phonate inside. I say that phonate inside that tone, find this flute tone. It's very interesting. When you release certain points, the flute tones adds up. For example, when you release psoas muscle, 2.8 kilohertz develops. When you release the femur head and the region, 3.1 to 3.2 kilohertz develops. So therefore, you have the spectrographic result, not because of this release, but also it's affecting the airway. Body is a whole system. I mean, the airway is not a very strict organ. It's a flexible organ. So the body posture, the myofascial systems are all connected with the hyoid to the larynx. So the hyoid posture and the laryngeal tube function is always affecting the voice quality. We can use in the practical manner.
Yeah, thank you so much. And I apologize that my camera is not working.
No problem.
Thank you very much, Rod. Thank you, Ismail. Tom, Philippe, Liza, Leslie, Xijing, Wolfram, Jacob, Seher, Ron Scherer, and Karina and me. Well, somebody wants to say something about the presentation of Xijing, of Ismail and Leslie. We are waiting for your presentation very eagerly in July. Yes, and also in April for the World Voice Day. Somebody wants to say something or comment something before we leave?
Well, I'll just say one
Yes?
thing
No?
about Chris, if I may.
Yes,
He
please,
was
Ron.
he was a great colleague, and we worked together on occasion. It was one aspect that I think quite humorous is that I've never heard anybody pronounce his name correctly except him. And he trained me once, and I forget what it's supposed to sound like. So I apologize for that.
I have
Yes, yes.
a little note. I
Yes.
he invites times for the Pacific Voice over the years in San Francisco, in Santa Clara, and the last one was online for Poland, and that I was just checking. It was 2022, and he was pretty eccentric and ADHD and unique and enthusiastic. And he always made me feel excited to, he was excited to help me share my work, and I was so grateful. And he was a host, and I have some wonderful, screenshots of the video that it was a live presentation that I did on vocal rehabilitation in 2022, and I missed. I'm sorry that I didn't stay in close contact with him after that. But when I think of him, I do get a big smile on my face because of his enthusiasm for life and his support for people who he thought were fun and had something to say. So I'm very appreciative for all his invitations over the years, and I at least I got to see him, and we had a good time in the online session. A few years ago. And one day I'm going to get to Poland. I've never been, and Popeil is Polish, and every Pole that I've met has been brilliant and enthusiastic and really good at what they do. So I would love to go sometime and visit different cities. I've got one coming up. Mateusz invited me for. It looks like Lodz, but it's pronounced Łódź, Łódź, Poland. So I do have a little Poland coming up this year, so I'm happy about that. But thank you, Chris, for your enthusiastic support and for being on the planet as long as you were. That's what I wanted to share.
Thank you, Liza. And thank you, Chris, for all the efforts doing these wonderful Pacific Voice conferences that we enjoy very much. And we were all the time complaining about how to say my name because he said Chavez on, das ist Chavez on, so on. So many really nice stories. So, dear friends, I thank you very, very much for your presence. We having working in this session. Xi Jing, thank you very much for your presentation, from your self-presentation also. Ismail, thank you very much for this wonderful myofascial presentation. And dear Leslie, very welcome and thank you for your self-presentation. And Philippe, I thank you dearly. You know, you are in my heart and Chris is also in my heart. Dear Tom and Sarah, great to see you. My dear Liza, I write to you and we shall have a Zoom, you and me, because I was like with a lot of things, but I don't forget your ideas and your proposals. Lieber Professor Wolfram Seidner, das war sehr schön. Ron Scherer, thank you very much for joining us. It's also a great pleasure and honor to have your comments with us. I miss your face, so please send me a photo. And Jacob Lieberman, thank you very much for joining us. And I thank you all again. And welcome, dear Leslie and dear Xi Jing. Bye-bye. See you soon, Sarah. Philippe, thank you.
Thank you, Eugenia. Thank you.
Bye, everybody.